Hello and welcome back to the Unlocked Potential podcast. On this week's episode, we have Conal Harpur. Conal is a psychotherapist who specialises in cognitive behavioural therapy. Today we spoke about anxiety, OCD and different mood disorders and where disorders like this stem from. I hope you enjoy. Thanks so much for coming on, Conal. I'm pronouncing your name right, am I?
You are, yes, indeed.
Yeah. So with your profession or what you're actually studying or career, so it's called, I'm just going to look back on my notes so I pronounce it properly, psychotherapist cognitive behavioural therapy.
That's correct, yeah.
Yeah. So what does that's OCD and stuff, isn't it? Anxiety.
Yeah.
So how would you explain that, like OCD and anxiety, like in detail?
Yeah, so I suppose OCD and anxiety are two different disorders. And so with anxiety disorders, it's like anxiety disorder is an umbrella term to incorporate things like generalized anxiety disorder, specific phobias, and health anxiety. They're the kind of three main ones. And then panic disorder is another one where people have recurring panic attacks. And then OCD is obsessive compulsive disorder. And that's categorized by having what are called intrusive thoughts, so unwanted thoughts, which are called obsessions. Okay. Yeah. And often those are what are called ego dystonic. And that means they're kind of morally disgusting to the person. Okay. So they're intrusive thoughts that we don't want, that kind of feel like absolutely wrong on every level in what we know ourselves to be. And then what people have is those obsessions come in. People kind of get very confused about why they're having these thoughts. They get very distressed about that and they get really anxious. And to get rid of the anxiety, they will complete what's called a compulsion, which is a behavior that they feel they must do to get rid of the anxiety caused by the obsession or the intrusive thought.
What do you mean they'll do a behavior to stop thinking? Like, what would that be?
Yeah, that's a really good question. So kind of classic OCD or obsessive compulsive disorder presentation will be, say, cleaning. Okay. So what would happen is that, like, I would have an intrusive thought that if I don't clean this counter, that you'll eat off it and you'll get poisoned and you will die. And if you die, it's my fault. Okay. So I'll get really distressed. I'll get really anxious. I'll be really worried about you. And so what I'll do is I'll clean the counter. And by cleaning the counter, I go, oh, phew, I feel a lot better. Demi is safe now that I've cleaned the counter. Okay. Yeah. But what'll happen is the more I clean, the more intrusive thoughts I'll get. And now I need to clean it every time you're going to use the counter. And that'll increase. And the amount of time I need to spend cleaning the counter will increase. And the number of times I'll need to clean the counter will increase. Because I feel I'm preventing a catastrophe by cleaning the counter.
So what do they need to do? Not do it then?
Yeah, so a combination of that. So when you're looking at treatment for OCD, you're kind of looking at kind of a couple of different stages. And the first are what are called cognitive interventions. So cognitions being thoughts. The idea is that you tackle people's thought process. So if my thought process around the cleaning is, if I don't clean the counter, Demi will die if she eats off it. Well, how likely is that to happen? And you try and challenge those thoughts and rationalize them out. Oftentimes what happens, people's anxiety goes up. And when their anxiety goes up, their ability to think clearly goes down. So that's why they get stuck and they can't rationalize. And so, like, I'm sure you've heard that expression, shut up, I can't hear myself think. Like, what's happening there in the brain is the amygdala, which is the Latin word for almond. It's about that size. That gets activated and it's like a siren that goes off in your brain. And what happens is that sends a message to the hypothalamus, which is a control center in the brain, which sends signals down to the adrenal glands on the kidneys, and that releases adrenaline, which is why you get the fight or flight. So you get really tense, you get your heart starts racing, you might start feeling the chest getting really tight, you might find short of breath. And in that level of distress that happens within a second, you can't really rationalize what the right thing to do is, and it's just easier to clean because it gets rid of all that.
Right. Okay.
And that's why they get really stuck with cleaning. So you start with cognitive interventions, which is challenging the thoughts, and then you move into kind of behavioural interventions. So
that's what you specialise in.
Yeah.
It's CBT.
CBT, that's right. Cognitive behavioural therapy.
Yeah, I'm not even going to try and pronounce it. I'll probably get it's like a tongue twister.
No, you got it right.
So what were you saying there? Sorry,
yeah, so the idea is that when you're trying to treat obsessive compulsive disorder, you're targeting the negative thoughts that people have, the intrusive thoughts or the obsessions. You're trying to reduce the kind of distress associated with them. And then you're trying to work on the behaviors, which is reducing the behavior systematically over a period of time to get down to a realistic goal. So for some clients, like I've had clients in the past where they have showered themselves with bleach to the point where their skin is like disintegrating and they're in extreme difficulty. And those people would often need to be treated with kind of a combination of pretty strong medications.
And that's OCD?
Yeah. So
why are they cleaning them? Because they think they're dirty?
Yeah. So it'll get to the stage where it just gets worse and worse and worse.
The thoughts of...
Yeah. They feel much worse.
Oh my God.
And that's obviously an extreme case of OCD where people are washing, but it would be very common. So hand washing is another very common behavior in OCD, a common compulsion. And unfortunately what happens is that over time, the more you do the behavior, so I'm kind of washing my hands here, the more I do this behavior, the more I need to do it. And the less comfortable I feel that I'm doing it enough. So it kind of goes from like, I'm using this one soap, now I'm using soap 1, 2, and 3. Right. Now I'm using 5 soaps, but that's not enough. I need an antiseptic as well. And now I'm actually, do you know what, I might try this cleaning product. So I might try Cif or a degreaser. And then I kind of go past the degreaser into bleach because I can't get anything stronger to wash the germs off. Because it's all about preventing the germs from spreading and harming other people. And that I'm responsible for that.
That is mad. Well, I've heard of someone counting steps every time they walk. What's that from?
That's a very...
why would that even come into, like, why do you need to count how many steps you're stepping? Like,
so a combination of reasons. So OCD is broken down into obsessions and compulsions, as I said, and there's different types of OCD. So some people will have what are called aggressive obsessions, where they will have, like, say, thoughts of, so if I have OCD, I might have thoughts of attacking you, or that I'll attack someone around me and I'll have intrusive images, or I might hurt my baby or my friend or whatever it is, and I'll get really distressed around that. So that's kind of an aggressive obsession. Some people have sexual obsessions, so that they might rape somebody or that they might attack somebody sexually, and that can be a really common one. A lot of kind of straight men struggle with obsessions of them having sex with gay men and things like that, and they get very distressed by it. A lot of women will also have kind of intrusive thoughts about them having kind of lesbian relationships with other women and stuff.
Oh my God, this is all
really
crazy.
Distressing. Yeah. But you see, the difficulty is that people, when they experience those, they do feel crazy, but they're not. They're just intrusive thoughts that they don't want, but they get the meaning mixed up. So you've kind of aggressive obsessions, sexual obsessions. Another one is religious. So people might blaspheme and say like, oh, I hate God in their head, and then go, oh my God, I can't believe I said that, and get really distressed about that. And then you kind of have ones relating to kind of hoarding or symmetry or cleaning is another one. So with the symmetry one, it's kind of around what kind of feels right for people. And so for some people, they need to do certain things in counting. Okay, so in certain numbers, whether that's kind of like they count odd numbers, even numbers. Like a really classic example is people who can't have the television or the radio on like a 3, like a 43. It has to be on a 45 or a 50 or whatever.
Right, okay. I feel like everyone has that.
I think everybody does that.
Yeah.
So the counting
I have that. I definitely do that.
So do I. Yeah. But I suppose in OCD, it's that people can't possibly have it on anything else. They need to have it on the 40 or 45 or 50. The same way that people who count steps, they might go up the stairs in 2 steps, or they might do a few steps a few times in a specific way. And the idea is that they're developing a ritual. And by completing the ritual from start to finish effectively, they are preventing a catastrophe. So when I meet you for the podcast today, okay, let's pretend that as I walk up the stairs, I say to myself, I need to take these 2 at a time. Otherwise, I will die on the podcast, or Demi will die on the podcast, right? And so I genuinely believe that my thoughts have that impact on reality. And it's really important that people can separate out their thoughts from reality, because oftentimes what happens in OCD is there's kind of like these major, what are called cognitive or thinking errors that occur. And one is that if I think something will happen, it will happen, right? So if I think something bad things are more likely to happen. And what I'd say to most people on that is that, like, if you think about winning the lotto, are you going to win the lotto? Most people go, Jesus, that's crazy. And you kind of think, well, why would it be different for bad things? Like, either your thoughts impact reality good and bad, or they don't impact reality at all. But people don't like to think about bad things.
Yeah, that's mad. I'm actually in shock.
Yeah, that's very common.
Learned a lot in the last 5 minutes.
Yeah,
and where do you think all this stems from? Like, where do you think?
Where do I think OCD stems from? I think OCD stems from a couple of different places. I think the main thing, there's some biological research that supports that people with OCD have kind of little bit of kind of maybe faulty wiring in inverted commas in the orbital-striatal cortex in the brain, okay, which is responsible for rewards. And then there's also
responsible for what, sorry?
For rewards. Rewards. So if I do something, I get the reward instantly. And then there's enough I suppose, historical research going all the way back to kind of 1919. Sigmund Freud, who's a psychoanalyst, he wrote about what's called the Rat Man case famously. And they kind of talk about how children grow up in unstable environments. All a child wants is consistency and some level of predictability. Like no child wants to grow up in a scary environment because it's awful for them, okay? What you'll often find is when children grow up in a very scary environment, they will do things to try and control the outcome of different things. So if you're my mom and, you know, John is my dad and you guys come home and you fight regularly, or there's a lot of drinking or things like that, a kind of reasonably toxic upbringing, like my world is really scary, right? Because you guys are the kind of guardians that police my earth. I need you guys to be okay. If you're okay, I'll be okay. If you're not, my world is very unpredictable. So I might start doing things like, you know, tapping my head a few times. And if I tap my head 3 times, mom and dad won't fight. And then one day, neither of you fight. I think, oh my God, it worked.
Right.
And so that can develop a little bit more. And it's all about trying to get control over their domain. And they're trying to basically, if they can control external factors, they'll feel okay. So that can often be a spawn point of OCD. A lot of people as well with OCD feel like they are bad people. And that's why they have these bad thoughts. And so they kind of really struggle to kind of break free of that, because when you're growing up, if you're a child, you don't have what's called theory of mind. So theory of mind is if you come home and you slam your bags down, you slam the door and you're kind of cursing and slamming plates down, I'd assume, she's had a bad day. Give her a miss for a while. You know what I mean? If you do that in the presence of a child, they assume it's their fault. They assume everything that happens in the world is because of them.
Can you say that again? Can you explain that again? Sorry.
Yeah. So with children, they personalize. So it's all about me, the person. Okay.
Right.
So if you come into the podcast studio, right, and you're slamming stuff down and you're kind of shouting at Dan in there and you're kind of giving out about things, I'll assume I have done something wrong if I'm a child.
Right, where it could be something like outside, something that happened that morning. Right,
exactly.
Okay.
But you need to have what's called theory of mind to understand that. You need to understand other people have other thoughts and behaviours and wishes and emotions and
the
impulses.
child doesn't get that.
No, absolutely not. So they associate anything bad that happens with them. Therefore, if bad things happen around them, they'll assume that they are a bad person unless the parent can teach them otherwise. So they try and make bad things not happen. That's their goal. And that might be around trying to control the environment. So like tapping the desk 5 times. And if I tap the desk 5 times, you know, Demi and Dan won't fight. And then it'll be a stable environment for the podcast. So I might just come in and go 1, 2, 3, 4, 5. And I go, oh, phew, thank God I'm okay. And then you and Dan don't fight. And I assume, oh, happy days. I'm in the clear here. Thank God I tapped the desk.
Yeah.
But now every podcast I do, I need to tap the desk 5 times. And now it's not just podcasts. Now it's I'm going to a meeting. If I tap the table 5 times, there won't be any distress. And I kind of carry that rule forward. And a lot of children, the age of onset, which is the age that OCD develops, in girls, it's around 9, 10. And in boys, it's about maybe between 11 and 13.
And why is that? Why is there like different ages for girls or boys?
I'm not actually sure on why that is. That's just kind of what's kind of the recorded age. But
how would they record that?
In studies, clinical studies.
From like having them being around them from like a young age until.
So oftentimes what happens is that. So sorry, when I say recorded for that kind of for kind of more formal research studies, the idea
someone
is,
would come in and say they have OCD from that age, right?
Exactly.
Okay, that's just kind of like what I heard.
No, not the parents. Yeah. So it'll be done in hospitals or done in that, like, and they record the data of the child and all that kind of stuff. So.
Yeah, that's mad. And what? So with anxiety, like what type of things will someone come in? Like what would they be experiencing?
So most commonly people would have what's called generalized anxiety disorder. And the best way to describe generalized anxiety disorder is it's kind of what if anxiety. Okay. So the idea is that if I'm driving here to meet you in the podcast today and I'm stuck in traffic, oh my God, if I'm stuck in traffic, then I won't make it to the podcast. If I don't make it to the podcast, that means I'll be late. If I'm late for the podcast, then Demi's going to fall out with me. If Demi falls out with me, then we're not going to have a good relationship and the podcast is going to go terribly. If the podcast goes terribly, boom, 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 boom. And it's getting worse and worse and worse and worse. And oftentimes when people get those thoughts, they have these really distressing kind of, the thoughts are going really fast in their head and they almost feel like they can't catch their own brain. It's kind of like brain fog, if you know what I mean. That's very common. That's kind of more generalized anxiety disorder. And people get very distressed around that, where it's kind of, and the idea generalized meaning it's like they worry about general things. So like loads of different things. Okay. Then another very common presentation is panic disorder. Panic disorder is basically where people have a panic attack. That obviously sounds very straightforward, but the idea is that after people have a panic attack, they believe that during the panic attack, they believe, I'm going to die, I'm going to lose control or go insane. They're the three things that people believe are going to happen to them, okay? And a panic attack, for those listening that don't understand it, it's where your chest tightens, your heart starts racing, you feel like you can't catch your breath, and you feel like this is the end, okay? It's extremely traumatizing for people. After they have those events, they feel like, that could happen to me at any time moving forward. Yeah. So anytime they feel like a little flutter in their heart, or anytime they feel a little bit of chest tightness. They might bring one on then. Yes, and that's where they really struggle. So a lot of people that come to me in CBT solutions will be suffering with kind of panic attacks a few times a week. I've had cases where people are having a few a day. So it depends on how extreme it is, but generally it's having quite a severe kind of impact. The other kind of secondary impact of that is what you get with panic disorder is what's called agoraphobia, okay? That's fear of open spaces. And what happens is that when people have panic attacks, they're kind of afraid to go outside because they think, oh God, what if I have a panic attack? I'll be either socially humiliated or I could die or something terrible could happen. So they stop going places and they start kind of staying at home more and more and more. And the idea of staying at home more and more is it becomes a safer place.
Or like in enclosed spaces as well, isn't it? Like yes. Lifts and stuff like that.
Yeah, that's another one, claustrophobia, yeah. And so people are kind of very stuck when they have either of those disorders. With the kind of knock-on effect of panic attack is that it tends to be a lot more personal because people are afraid to go out and do things, so it more impacts them. With generalized anxiety disorder, people have a lot of distress that actually kind of impacts their family members. So if I do the podcast with you and you have generalized anxiety disorder, like you might be looking for reassurance on lots of different things that are going on in your life, right? And I can kind of give you the reassurance because we're here for a set period of time and I don't mind for whatever, I'd have to give you the hour or whatever it might be for the reassurance. But if I lived with you as a roommate and there was two other people in the house as well, and you were going around asking us for reassurance all of the time, we'd all kind of start to kind of maybe lose a bit of patience with you. Yeah. And it can sabotage relationships because you'll be kind of going over the same stuff over and over. And, what do you think I should do about this? And do you reckon that'll work like that? You're not, like, the reassurance only provides temporary relief. It doesn't help you long term.
So I seen a video before on Instagram or TikTok it was, and it was like trust in relationships, not trusting someone. And it was basically saying you're gonna end up breaking up because you're not trusting them, so you're gonna keep asking for reassurance, and then they're getting annoyed. I seen something like that a couple of years ago. And how would you fix that then, instead of without asking for reassurance?
Yeah, that's a really good question. So I suppose then that comes down to your own level of insecurity in relationship. I don't mean you, but in general, people's own level of insecurity in relationships, and what is it about the person they don't trust? Like maybe they've got really good grounds to not trust that person. Yeah. So like if your partner is kind of actively kind of liking other girls' photos on Instagram and messaging them all the time, and you've kind of asked us, and he keeps doing it, like that's not really trustworthy behavior. Do you know what I mean? So that's kind of fair enough. And in which case I'd be more inclined to ask the woman in that situation, like, why are you staying with him if he's treating you like that?
Exactly, yeah.
However, if you're in a very stable relationship and you still don't feel safe, then you might have a kind of anxious attachment where you feel, and that comes from attachment theory, which is kind of by John Bowlby is his name, and that would have kind of come out in the 60s. And it's the idea that we have attachment styles. So the way that we are with parents can often influence the way we are in our relationships growing up. So if I have a very secure relationship with my mum and my dad, and it's very stable, it's down the middle, I know where I stand, I expect all relationships to be like that. So my relationships are kind of like that. Whereas if I don't know where I stand with my mum and I'm kind of, she's a little bit like kind of maybe critical of me, or she's a little bit hostile, or she kind of withdraws love based on my behavior, so it's not unconditional love, I kind of get a little bit anxious around that and I don't really know where I stand. So I might try and get the love I didn't get from her from my partner. And the difficulty is that like it's never going to be enough. It's never going to fulfill me because it's a childhood wound I have, which makes me feel unloved. And by me asking, are you sure you still love me? Are you sure this is working out? Are you sure you're happy? And you're like, yeah, each time. But I don't really believe you because it's a childhood wound. It's not enough.
So how would you fix that then?
Yeah, so that's working with people's kind of attachment styles and really working with that kind of what's called the inner child work to try and tap into the trauma that they've experienced. And trauma, I'm not using that word too loosely, but the idea is it's a spectrum, right? So what traumatizes one child won't traumatize another. And so like for some children, it's all relative, right? So like I've had people who've been sexually abused as children and they'll say, oh, well, thank God I was never beaten up. And you'll have someone who was beaten up saying, God, thank God I was never sexually abused. So it's all relative. Do you know what I mean? And so for a lot of people growing up though, they might have had maybe a little bit of unstable relationships with parents. It's not a trauma in that it's a once-off event or something that's happened on a couple of occasions. It's a case of it's happened daily for a period of time. And it's not until they kind of get to a later life and they move out of home and they're away from their parents that they realize, ooh, maybe I'm not okay in relationships. And it's about kind of going back and looking at that accumulative, that kind of combined build up over time.
Yeah, that's why I feel like counselling is good for anyone. Like everyone has some sort of like issues or anything that they could really work on.
Yeah.
Like that's I feel like it's real looked upon like that there's something wrong with you if you go to it. Like I'd be thinking if I like when I have kids, like right now I was only saying to you earlier on, I'm trying to find another counsellor just to kind of make myself as a better person in things that I need to work on. Or like the fact that affects kids growing up so much.
Oh, it's huge.
Yeah, that like I'm like I wouldn't want to impact my kids in any way from what I've kind of grown up around or so I think counselling like is probably way forward for everyone.
Yeah, and I think it's about trying to find the right type of counselling.
Yeah.
And so like a lot of people probably don't know this, but like psychotherapy is not a protected term in Ireland. So anyone can be a psychotherapist. Like if you put up a plaque on the podcast door today, there you go, you can have patients walking in the door to see it. Do you know what I mean?
Yeah. That's the one thing that I was saying to you that I didn't realise. I thought like you have to have some qualifications behind you to actually do this. Like
no, you don't. I do though, just for just for the record.
Yeah.
But what I would always suggest with people going to counselling or whatever it is to try and ask yourself before you go, if you're going to do 10, 12, 15 sessions with this person, what do you want to be different at the end of those sessions? Because it's not good enough to go in and have an idle chat with people if it's kind of just talking around issues, because what happens over time is you get stuck in circular conversations. And if you're doing grief counselling, if you're doing something like that, that's reasonably okay because you're trying to come to terms with a loss and you're going through an actual process of change. And sometimes counselling can be like facilitative. So it's like you're just allowing the conversation to unfold over a period of time. But there should also be a stage of kind of action where it's like, okay, I think we've kind of come to the realization where you've got problem A, B, and C in your life. What do you want to do about tackling this? And how long do you want to actually spend doing this? Because if you're spending 100 and something euro a session, you should really be expecting some kind of results from it, you know, and you should be putting in work in between the sessions as well. So a lot of clients that come to us, like we actually expect a huge amount from clients, which is kind of weird because they're paying us. But the idea is that like, if you're not going to do the work in between sessions, you're not going to improve. And that's not really rewarding for me to work with, like, just because I'm getting paid. Like, I don't really care about getting paid. It's more about that you're trying to progress and you want the best for yourself. And so I always say to people, what do you want to be different? If we did 5 sessions between now and 5 weeks, how do you want to be that's in any way different? Is that like different about, like, say, asking for reassurance in a relationship, which means you need to look at kind of childhood work? Is that around kind of you want to stop, I don't know, cleaning the sinks with your OCD? What is it and how realistic is it to do it and what's the time frame? And then we can kind of attack the problem together.
So if someone was to say, come to yourself, what would you like? Actually write out a list of things that you want to improve with yourself as a person.
Absolutely.
And then what would be like, what is it that you were saying doing the work in between sessions? So what would be that type of work?
So it depends on what it is. So like a lot of, I have a lot of corporate clients that come to me for assertiveness training. And like,
what's that, sorry?
So it's how to be more assertive and kind of stand up for yourself in the workplace. So it might be a case of like, I want to stop my boss kind of running me down, or I want to stop doing jobs that are beneath me in work, and how do I kind of assert myself and put myself in that position? So you kind of do a little bit of kind of confidence or self-esteem training to help them have that.
And have you got a few people coming in for that?
Yeah, a lot of people, I'd say about 15% of people I see would be kind of coming in from the corporate world. So it would be kind of people in kind of pharmaceutical companies, corporate companies that are looking to try and go, like, I want to try and get a promotion, but I need to put my foot forward. And I
never even think that was available for anyone.
Yeah. And normally people do really well in 5 sessions of that, because it's all around kind of role play based, challenging them, emotional regulations, cognitive restructuring, and kind of working with them to teach them a battery of skills for a very specific problem. So that'd be kind of around 15 to 20% of people will be coming for that.
So what would be this, bringing it back then, what would be the sessions in between then?
Yeah, so it'd be kind of work on specific things that you would be trying to achieve. So like, let's pretend that it's the assertiveness training, for example. What you would do is you would put people in positions that challenge them. So
would you turn around and say, right, when you go in to work this week, make sure you say this or do that? Oh,
absolutely,
right, okay.
yeah. Because the idea is you're trying to practice, but you practice on like a hierarchy or a list, and it gets easier as you go up. Or sorry, it gets harder as you go up. So you start with the easiest people in your life. So what I get people to do is kind of write out a list of 10 people they know in their lives. Okay. And you say, who would be the easiest person to challenge and who would be the hardest person to challenge, right? And so it's all about kind of stating your values and what you want for yourself without kind of being selfish and narcissistic. Like, it has to be realistic as well. And so you kind of work your way up through the list, and the idea is it's a little bit more challenging every time you do it. So you come back and we learn skills, and we kind of, okay, where did you fall down when you practiced it during the week? Because you would have done reflective work, because that's part of coming to the clinic as well. If you haven't done that and you haven't practiced, there's no point coming back to me. Someone else can take your slot and they'll be more willing to work.
Yeah.
And like, obviously there's a kind of a little bit of leniency with that as well. Like, we're not expecting people to kind of come back with 10,000 word essays or anything, but we want people to be in a position where they're putting their best foot forward. The same way if you go to a physio and he gives you stretches, like, why would you not do the stretches in between the physio sessions?
Yeah. And when you were talking about phobias, what would that be? Would that be like, would someone come to you and be like, I'm afraid of spiders?
Yes.
Has there?
Yeah.
Oh my God, stop it. Like,
yeah.
Like what? Like if they see one, or do they constantly think there's spiders around them, or what? To what extent is that?
Well, if they constantly see spiders around them, they're probably very unwell.
No, I mean as in like not see spiders. Sorry, I mean like they're constantly thinking there's a spider somewhere in the room. Is that what?
So it might be a case that so when you're talking about phobias, you're not talking about someone who sees a spider in a bathtub and screams and runs out of the room.
Right? Okay.
We're talking about people who have a very prolonged, ingrained fear that this is going to be some kind of threat to life. It's not like kind of, oh, there's a spider, I need to get out of the room and someone get that spider for me. It's like, oh Christ, there's a spider in the house. I don't know if I can stay in the house.
Right. I'd be like that now. If I seen a big spider in my room, if I didn't get it, I would be gone.
But see, for a lot of people, even with phobias, they might think, oh, there's another one. Like where there's one, there's more.
To be honest, I did think that slightly, but then I was like, I'll just get on with it. I don't think, hopefully it's not.
You need help. So like most people that come to me for phobias and come to the practice, they're coming for what's called cynophobia, CYNO, which is a fear of dogs.
I was thinking that would that be one of them if they've got bitten by a dog when they were younger common. And stuff, yeah.
And there's kind of two ways to develop phobias. One is that like the dog directly bites them. And the other one is what's called like learned or acquired fears through watching others. Okay?
Which, sorry,
I'll explain that. So the idea is like if you're my mom, right? And as I said to you earlier, like I need to kind of feel safe. So if you're solid, I'm solid. Do you get me? Right. And so the idea is you're huge compared to me, right? Like you're like, I'm 3 foot tall. You're a monster. You can move me out of the way. Like you're kind of living God to me, right? And so if you're scared of something, how do you think I'm going to feel?
Right, yeah, because you look up to them.
Absolutely.
If they're scared of something, you're only a little, you're like, I should be scared of them as well.
Yeah. So if every time there's a dog and my mom screams and tries to run away and grabs me, I get really frightened.
That's probably where all the fear of spiders
That's where it comes, yeah, it's acquired.
And bees, because we, like when we're younger, we're obviously being around people screaming around all that, so we think there's something scary about them.
Yeah.
Yeah, I don't understand why I have a fear of like, the bees and stuff don't really do anything, don't they not?
Well, they sting you.
Yeah, well, I mean, as in like, unless you've actually like, do something to them, or
yeah, like I mean, they're not going to rob your house or come after you or anything. Do you know what I mean? But like, they're definitely like what people are afraid of the unknown. So with phobias, people are either afraid because they've had a direct experience with the thing that makes them afraid, or they have learned a fear
from somebody else.
So mom gets scared when she sees spiders as a child. Like, oh my God, same way people have fear of mice, because when they have mice in the house, you know, parents scream or react badly. Whereas if I'm with a parent and there's a mouse in the house and the parent goes, don't worry, look, we'll just get the mouse, we'll get the traps, we'll kill it, it's not going to hurt you. You kind of go, I don't need to be afraid of the mouse. Do you know what I mean?
Yeah,
so how they react can determine your capacity to develop the fear.
Yeah. And you worked in, so what made you actually get into this? Like,
a combination of factors. I think that my primary degree was psychiatric nursing. And I wasn't really sure if that was for me, and I kind of wanted to see what I could do that was more kind of one-to-one work, because I've always believed in trying to unlock I suppose not to
Yeah, as
name
a
your
podcast,
podcast. Yeah. But I do believe that like everybody has an awful lot of potential that's buried deep down within them, and they need the right people in their lives to come along and help them get that out. And I've always been fascinated by what makes people great, and like, you know,
What way the mind works and stuff.
Yeah, and how they tap into that. And I suppose that I grew up in my house. My mum was a consultant psychiatrist for child and adolescents, and it was always interesting to hear her kind of interpretation of people.
Oh, so she worked with kids.
Yeah,
I'd say so. She was probably a really good role model to be around. Like.
She's fantastic.
Yeah,
she
still is. Exactly what
she still
to
is.
Say,
and she did, and she was very stable and solid. And I think that as you kind of grow up, and I appreciated that psychological insight a lot, and I was kind of like, oh, I would like to have that for myself a little bit. And I found cognitive behavioural therapy, and it just clicked with me. It just made sense. And I think I was very lucky because I found something that really worked for me at an age where I would have otherwise maybe been a little bit stuck and not know where to go. And so I kind of pursued the postgraduate certificate, the postgrad diploma. I was very lucky. I got to research with a fantastic psychiatrist in Trinity College, Dr. Brian Fitzmaurice, who was an excellent mentor for me, and carried that research into my master's. And yeah, so I just kind of fell in love with it basically from day one.
And you worked in St. James's as well, didn't you?
I did, yeah.
And what was that, the same kind of working with like OCD and?
So the role in James's was kind of split. So I worked in the locked psychiatric unit, which was people who were extremely unwell. So oftentimes brought in under the Mental Health Act, they're detained against their will, or in from prisons or different things like that.
That was fairly frightening, wasn't it? No?
No, I didn't. I didn't find it frightening. I found it, I loved it because like you never knew from one day to the next what was going to happen. It was a great team. The management were great. So overall, it was just a fantastic place to work, and I really enjoyed it. But I knew it kind of had a lifespan as well, because obviously in that working environment, there can be a high rate of assaults and there's a high rate of burnout and things like that. So I knew that for the period of time that I was there was excellent, but I always wanted to transition and do my own thing and kind of have my own practice and my own kind of, business eventually. And so I was between the locked unit and between the psychology department in James's, and that treats kind of very complex cases. And I was actually very fortunate, another great mentor there, Dr. Andrea Langaro, who was supervised me for my cases, and it was people with multiple coexisting mental health problems. Yeah. So people would have maybe anxiety disorder, they might have depression, they might also have kind of some kind of personality disorder, and there might be a history of abuse and some addiction and different things. So it was very challenging at the time for the level that I was at, but obviously as I worked there for longer, I kind of became more okay with the cases and kind of great learning environment. Yeah.
Was your head not all over the place when you were going home?
No.
I'd take that home with me. I'd be sitting there going, oh my God.
No, I'm very lucky in that. Like, I think I'm pretty boundaried, and I feel that like once I'm doing the best that I can for clients, then I can't do any more. Do you know what I mean? Like obviously obviously you hear certain stories where, people have experienced extreme trauma as a child, and that kind of, you kind of think, oh God, how sad for the adult that's in front of me, but also for the child that was. And that can be, that can sometimes be a little bit upsetting, but I think you need to feel a little bit upset for those things because they are upsetting. So, it's about trying to boundary that. But I engage in supervision every week, and it's a chance to discuss cases if I'm very distressed about them, but that doesn't happen.
So does anyone ever come to you like trying to get help from stress, like say from, how would you help someone deal with stress?
So the first thing you would do is you would try and figure out how long they've been stressed for, if there's any other periods in life that they've been stressed, and what exactly is it that's causing them stress at the moment. So for most people, that come to me in private practice, they tend to be working professionals, and so like the stress is either relationship stress, so either they've had an affair and they're trying to come to terms with it and trying to figure that out with their own partners, or the partners have had an affair, so there can be relationship issues, or they're fighting a lot, or they're separating, so there's relationship issues. And then there's also kind of professional issues, so like they're getting bullied in work, or they're struggling with their boss, or they're not happy in their role. And then there's kind of more personal issues where they might have low self-esteem. And so you're trying to find out what exactly is it in their life that's causing the stress, and then trying to think, okay, well, if X is causing the stress, if we were to do 10 sessions together, would you like to be able to like, how would you like to be able to deal with X after the 10 sessions?
Yeah.
And if they say, I'm going to leave my job, then there's no point coming to me, because you're going to leave your job, so the stress is gone.
Yeah.
Do you know what I mean? So
it's about... See the way you're saying, like, 10 sessions and stuff like that, is that like kind of like someone will come to you for 10 sessions and they don't come to you again? Or like, do you ever get some people go to counselling and they always go to counselling?
Yeah.
Like you said, would you have like clients that come to you all the time, like weekly?
No, not weekly all the time. So I would have, my clients are, I would describe 90% of my clients as people who've been to therapy before and it hasn't worked out, or they haven't clicked, or they just felt the person wasn't great, or whatever the case might be. And they're kind of coming to me as a little bit of a last chance saloon, kind of going, listen, kind of prove yourself that you're actually going to be solid. Because obviously, they're paying a certain amount of money, they expect a certain service, and they expect to get results from that. And I think they should, like, you know what I mean? I think people should go to therapy, not kind of going in for a kind of happy chat and to come out feeling better. Like, you should be coming in with a very determined mindset that, like, I want to be able to do X, Y, and Z in my life that I can't do now. And so, like, I set blocks of sessions with clients because it keeps people honest. And it also makes me kind of think, what are we doing here? Where are we going? And I think that people don't know what to look for in counselling or psychotherapy, and there's a difference between counselling and psychotherapy. Counselling is more like where you listen to the person, you try and draw it out. Psychotherapy, especially cognitive behavioural therapy, is far more direct. So I'd be inclined to say things like, well, okay, well, you say you want that, but actually you're doing this. So how do the two things make sense? And putting a bit of responsibility back on people and trying to help them kind of work things out. But normally what happens with people is they attend for anywhere between 10 to 20 sessions weekly. And then in some cases, it's a complete discharge from that. And they go off and do their own thing. And then for others, it's like, they're like, do you know what, can I come back to you next month? And you might do 3 monthly sessions. And then after that, you might go, I'll see you in 3 months, or whatever that might be. And the idea is that you kind of stretch it out to 6 months, and then people can come back kind of once a year, similar as you would do your bloods in the GP. Do you know what I mean? So they link in for that. So it's more supportive. And then there's some clients that obviously can't afford to do it weekly, so they might try and do it fortnightly or whatever way works for them.
Yeah. And then, so where, like, would you have anyone coming into you and saying they have like an eating disorder or like that?
Yes.
Yeah.
Regularly.
Yeah. So how would you help that? Like, how would you?
So with eating disorders, you need to be...
that is mental, isn't it? Kind of like, I think that they have in their head why they're not eating, or they are binge eating, say.
Yeah, so you need to be very careful with eating disorders. Like bulimia nervosa, which is kind of more along the lines of restricting than binging and things like that, where it's more impulsive and kind of what can seem a little bit more chaotic to the general public. That is reasonably difficult to treat at times, but it's a lot of kind of self-esteem work and kind of going through other issues that have happened in their life. Whereas anorexia nervosa, where people are kind of severely underweight. So like, I've met people who are, 5'5" and they're 37 kilos, like they are extremely malnourished. We tend to encourage people with anorexia nervosa to engage with an adult mental health service purely because there's so many other medical constraints attached to that kind of disorder. So if people have anorexia and they're coming to me, but if they're not eating, like there is a genuine risk to life. And I don't have a medical team working with me that can do your bloods, your blood pressure, check in on your kind of fat levels, your weight, all that kind of stuff. That really needs to be handled by a specialist team. And there is plenty of eating disorder kind of services around the country for people with anorexia where it's quite severe.
Yeah. And what would you say for, like, say binge eating? Let's say, for example, like me, I tend to binge eat when I'm stressed.
Yeah.
So how would you help that?
Well, I'd be trying to target what the kind of things are that make you stressed and why you can't tolerate stress.
It's like, for me, it's kind of like when I'm working from home and I'm like, I think I look at that as a procrastination or something. I start a task and it's like, I'm like, I go to my kitchen before I even start it.
Yeah.
Yeah. And then, like when I'm working from home, it's,
So some people do that because they're trying to... There's a kind of punishment element to it, and sometimes there's a motivational element to it, and the kind of thing that you're talking about, where they're like, oh, sure, I'll get a Kit Kat and start my work then. And it's kind of like, oh, because I'm eating the Kit Kat, I feel a bit better, so I'm going to work a little bit harder, or whatever the case might be.
Then when it finishes, you're like, what else is in the press?
Yeah, and I suppose that's when it kind of maybe gets a little bit more challenging people. And so there's a lot of kind of emotional regulation techniques that you're trying to get people to do.
Yeah.
oftentimes when people are kind of working from home and they feel like an impulsive urge to kind of eat, that impulsive urge to just jump up and eat is a little bit of kind of just not being settled in yourself. There's an emotional distress taking place, but it happens so quickly and people don't want to sit with it. They just want to go, oh, I'm just going to grab something to eat. And it becomes a pattern of behavior. So part of it's trying to break the pattern, but also part of it is trying to go, well, what is it about you that you can't tolerate in that moment that you feel you need to go and do that? And how do we kind of learn skills to not do that? This big task
that you're kind of like, oh my God.
Yeah, so it's about reframing the way you view food as well and your whole belief system about food and, you know, and trying to work obviously towards a more balanced lifestyle is the optimal goal.
I started going to the library.
Did you? Well, there you go. Yeah.
I'm like, get away from that kitchen.
But that's a very good way of managing it. Do you know what I mean? It's more longer term if you find yourself in the position where you can't go to the library, or if COVID kicks in again, you're kind of at home, you're like, oh no, the bag of Kit Kats is gone. Do you know what I mean? Or whatever it might be.
Or just stop buying the junk food.
You can start doing that too, but then you just get deliveries. Do you know what I mean? You'll always find a way around it. So it's more about targeting like what's the source of the problem in the first place.
So with the podcast, like, or with the chat that we're having right now, what is the awareness that you're trying to bring into?
I'm trying to get people to see that psychotherapy in Ireland is a dangerous business if you're a client, because there is a lot of people out there practicing psychotherapy who are not qualified and shouldn't be practicing psychotherapy. It's not a protected term. There was a primetime documentary done on it recently. It shows how easy it is to do it. And
what is this documentary?
It's Primetime Investigates,
Okay.
But I want people to know that like you should expect a certain level of professionalism from psychotherapists, and that, you know, you should also be going in with an idea of what you want to get from it. And if you don't have that idea, that's okay. But the therapist should help you be able to kind of work that out, to chisel some goals from it. Like it should be somewhat goal focused. It doesn't need to be kind of pedantically all about goals all the time. But there needs to be a certain sense that we're working in a kind of direction. And we can kind of, you know, it's like driving on a motorway. It's a straight road to get to where you want to go. But sometimes, you know, you might need to take a side road and take a bit of a scenic route and explore what's down there. And then, but you're coming back to the motorway to kind of follow that goal. And a lot of people don't get that. And what happens for a lot of, say, clients that I would have had in the past and that come to me now is that they've been to therapy where it's kind of like 70, 80 euro a week. And they kind of feel like it's like, and I don't mean this like disrespectfully, like I know that's a lot of money to people, but they feel like, oh, I can afford 70 or 80 euro a week between, you know, the household expenses for.
Yeah, but if
like,
it's not doing that or it's not working, what's the point?
But see, if you don't know what you're looking for, so if you pay 70 euro and you come out of that session going, I feel great. Well, like that's super. You feel great in that moment, but therapy's not there to make you feel great coming out of it. Therapy's there to help you work through difficult emotions to work towards a goal. Like I hope all my clients come out of my therapy sessions feeling great, but I don't want them to feel great. That's not the goal. And so Fritz Perls, who's the father of what's called Gestalt psychology, describes therapy as a safe emergency, where, you know, you feel like something's wrong or you don't feel good in yourself, but you know it's happening in a safe way that you can process it and work through it. The idea is that therapy helps you work towards becoming a stronger person in yourself, not to make you feel good after one session. It's not a pick-me-up.
Yeah, and that's what I was saying to you. I went to someone and I went to 2 different counsellors now. The first time I felt like I just spoke, and I don't even think she even spoke to me. It was just like, and how do you feel about that? And how do you feel about that? And I was just kind of like, I was like, what? Like, she's not even really helping me or going through how I can make this feel better or whatever. And then with the next girl that I went, I thought that was a little bit better. But that's what you're kind of saying. I felt like I kind of went to it, felt better at that time. And then, so I just kind of stopped going.
Yeah, I can understand why you would. And that's what a lot of my clients have done well in the past, is that they've gone to therapy at difficult times and they've gone for maybe 10, 15, 20 sessions and been like, this isn't worth the hassle. Do you know, it's just, it felt really good at the start. And after about 8, 10 sessions, they were like, I still feel okay. But what happens is over time, you don't feel as good coming out of the sessions and your problems are the same.
Yeah.
And then they're kind of like, okay, I'm 20 sessions in, my problems haven't changed. I'm not able to deal with my problems better, but I don't feel as good coming out of the psychotherapy room. And they're like, I don't want to let my therapist down. I don't want to disappoint them. So they just don't go to therapy anymore. You know, rather than just saying, listen, I don't feel I'm getting what I should be getting out of it. You know, and you know, at the end of the day, people are paying for a service. They should be entitled to get results from the service. Like if I go to you and you kind of are in the kind of beauty industry, like I expect to come out looking a certain way if I go to you. Do you know what I mean? And if I don't, well, I might turn around and go, that's actually not what I expected. Do you know what I mean?
Yeah.
But people don't do that with therapists.
It's because I think, like, if you'd say, for example, you did go get your nails done, you know what to expect from a set of nails as a girl, obviously. Yeah. You probably wouldn't.
No, I wouldn't.
And then obviously from like, when I was going, I was just like, because I'd never done it, I was like, what way does this work? Is that the way it is? Do I just like tell her all my problems and she just listens? Like, I was obviously, for anyone listening, I was going for like stress or whatever. As wasn't washing myself with bleach or anything like that.
It's good to know.
But yeah, like, so I didn't know what to look for. I just kind of kept going for a few weeks, and that's the same. I was just kind of like, just paying it, thinking it's gonna. Everyone was saying, give it time. But then anyone who I do talk to who has done, went to therapists and done counselling, the amount of people that say they have to jump from therapist to therapist until they find the right one, but they probably didn't know what to be looking for, but one actually just helped more than the other.
Yeah, and you see, sometimes it's a case of like they just find someone that's just a little bit better than the rest. Like that's fine, that'll do for now, because they're just so jaded and so annoyed with the process.
And they don't know what to be looking for. They think this therapist is amazing, but they're probably not even as good as someone else that they could find.
But imagine if every time you went to your GP, imagine you'd got a problem that took a few weeks to solve, right? And the idea is that by going to your GP, they give you medications. So every week you get a new medication, and the idea is that the medication should work. Like, if the medications didn't work within the first 2 weeks, you'd stop going to your GP and you'd be like, listen, what's the story? I want to know why I'm not getting better. And you'd be asking the questions.
Yeah.
Whereas people's problems psychologically, they build up so slowly over time that they kind of get used to it. And they're kind of like, oh, well, it's taken so long to get here. Like, it's not that big of a deal as it was, but it flares up at different times. So they kind of end up with these peaks and troughs kind of metric, you know? And so it's really important that people just say, when you go into therapy, listen, here's what it actually like to get out of doing this. And your therapist can very quickly turn around and say, listen, I'm actually not the right person to help you do that. And that's fine.
When I was looking up therapists, I obviously just seen, to be honest now, when I think about it, I think your picture popped up, but I don't know why. I was trying to go into the details. My friend sent me a site. I started getting panic attacks from stress and stuff like that. My friend sent me a site.
Sorry to hear that.
And I was looking at like it said like what they specialise in. And I didn't even understand half of it.
Yeah.
I was like, is that suited for me? Is that person suited for me? And I think I just rang a few people around, and I was just like, all right, whoever had the appointment or whatever. So I feel like most of the time people are probably like me, they don't know what to be looking for. And the therapists are probably specialised in different things, aren't they?
Yeah, absolutely.
Yeah.
And so for people listening, the idea to think about this is that psychotherapy is an umbrella term, right?
Yeah, when people hear psycho, they think, oh, there's something completely mentally wrong with me. I shouldn't be going to therapy. When, as I said saying earlier on, I'd love to kind of consistently go somewhere when I do have kids. So for parenting as well, that'd help.
But if you do it before you have kids, you won't need to go when you have kids, because you might not have the time when you have the kids.
Yeah.
But the word psycho comes from the Greek word psyche, which means soul. And so it's therapy for the soul. But psych, in the way we understand it, is psych of the mind. Okay, but originally that's to do with soul from the Greek word. So it's around like who you are as a person and what you want, your values, where you want to develop to, and stuff like that. But for people that are looking for therapists, like I understand it's a really daunting task. It's quite a scary one, because you're like, oh, I don't know if I want to talk to someone about this, and I don't want to tell them that, and then they kind of doesn't work out. It's worth kind of thinking that under psychotherapy, you've got cognitive behavioural therapy, which is what we do at cbtsolutions.ie. Then you have like psychoanalysis, okay, or psychodynamic. And then you also have humanistic.
What's the psychoanalysis? Sorry.
So no, you're fine. So that's kind of one of the earliest forms of psychotherapy that was kind of released released on DVD, but but the idea is that like you are kind of working with a kind of the subconscious, the parts of the kind of thought process that we don't really understand, and it's kind of hidden from us. So it's kind of talking about that, try and bring it out, and it's kind of looking at your kind of relationships with your parents and stuff like that, and try to make sense of it all. But there's kind of different models of psychoanalysis. And so in some cases, I think there's a Uruguayan, a German, and I can't remember the final model, but the idea is that you might have to go 2 or 3 times a week, and that can go on for 2 years. So that's obviously extremely time consuming for people, and it kind of lacks the evidence at the moment. There's people kind of want to get fixed, they're not broken, but they want to kind of get progress reasonably quickly. And psychoanalysis is maybe not the right approach for a lot of people. It's a very different, unique approach. So like you've got to get all these approaches, and I suppose the reason that people go for CBT is because the most amount of evidence has been done on CBT. So we know that CBT works, besides cognitive behavioural therapy, we know that works for anxiety disorders, so specific phobias, so your spiders. We know it works for health anxiety. We know it works for generalised anxiety disorder. We know it works for depression, for low self-esteem, for low mood, for obsessive compulsive disorder, for PTSD. And under CBT, you have what's called third wave CBT, which is kind of like the focus on emotions and deeper processes. So you have things like schema therapy. So Jeff Young in 2001 wrote a fantastic book on schema therapy. And in 1993 did a brilliant article on schema therapy with Bricker. And so like schema therapy is excellent because it's about reparenting and looking at like how repeated interactions with primary caregivers, so repeated interactions with parents, tend to foster a certain way of thinking. So schema is a cognitive affective, so a thought, feeling kind of style that we enter into that results in certain behaviours. Yeah. And so if your therapist is offering you CBT and they're skilled enough to understand the third wave integration, so like that's acceptance commitment therapy, compassion focused therapy, schema therapy, as I said to you, mindfulness based cognitive behavioural therapy, and to a certain extent imagery rescripting can maybe fit into there somehow, but there's lots more approaches within CBT that are far more evidence-backed and are actually shown to work than there are in all of the other psychotherapies combined. Yeah. And that's why people are going for CBT. But again, you want someone who's not kind of just done a one-day workshop in CBT. You want someone who's kind of maybe done a good bit of training in it just to get...
And has experience.
Yeah. Well, like I if I'm getting my nails done, which I probably won't be, but I'm probably going to go to someone like you who trains students and is very good at it. Do you know what I mean? Because I want someone that's going to be the best at it. I'm not going to go to someone and take a chance on just saving a few quid, because why would I? Like, you know what I mean?
Saying that, some people do.
Well, of course they do.
They don't see the that's the same thing with counselling or anything.
Yeah.
They don't see the value of paying when they can get it for cheaper.
And if you can get the same quality for cheaper, 100% do it. Do you know what I mean? Like if I can get the same stuff that's in Marks and Spencer's and Lidl, I'll go to Lidl. Do you know what I mean? But that's just not the way it is at the moment. And most people will, if they have the means, pursue the highest quality they can, you know? Yeah. So if people can afford to get their nails done at 100 quid, I've no idea how much nails cost. But if like say 100 quid is like the top level to get your nails done in Ireland, and 50 quid is the medium range and 75 is kind of medium to high. If people have the €75, they'll go for the 75 if it's important enough for them. And for some people, they'll sacrifice the money to get the €100 to get it. Do you know what I mean? To get the highest quality. And like what we say to people all the time is that, like, you know, a night out costs what, about 150, €200 now. Do you know what I mean?
Exactly.
So you're basically
what are you prioritising?
Do you know, if is it more important to go on your night out? Maybe it is. It could be a great night out. But is it long term? Is it going to fix the problems that you have? And if it doesn't, then it might be worth trying to figure out, you know, it's about kind of sacrificing something for what's more important. Do you know what I mean?
Yeah. And like you could be going to a counsellor paying whatever, 60, 70 euro. And then how many times have you paid that? What does that add up to? Then that didn't sort any of your problems. Well, you know, so I might as well just go somewhere and pay more. And then that, and then as you said, it's probably like what, 10 sessions?
10 to 15, depending. Yeah. Like I had a woman and she was attending a counsellor for a year, and it was about, I think it was 70 something euro a week she was seeing them. And she got really burnt out, really annoyed, didn't make the progress, and she came and I did 12 sessions with her and I haven't seen her since. So
and have you heard from her to say that like everything?
I saw her like 6 months later and she was still doing really well. So like,
and what would she have been kind of struggling with?
So it would have been kind of low self-esteem and kind of a lot of relationship issues, and especially around kind of asserting her needs and what she wanted from it.
Oh, right, okay, yeah.
Yeah,
I've learned so much from
Great.
from this episode. Good. I'm like, you have me sold. I'll probably be going to come to you now. Because I was actually thinking, I kept saying, I'm putting on the long finger. I'm like, I need to find someone just for my own kind of thing. And I just come like, oh, I haven't got time today. I'll do it tomorrow.
Yeah,
you know, you're after coming to me. I didn't have to look.
There you go. You brought the mountain to Muhammad. But I think it's important for everybody to kind of think, you know, like if it's something you're thinking about doing, like whether you come to us at cbtsolutions.ie or you go to anywhere, the most important thing to ask yourself is, what do I actually want to get out of it?
Yeah.
it's not really who you go to or when you go to them. It's like, if I'm bothered going, like, what is in your life that's causing you that many problems, excuse me. And what do you want to do? You do 10 sessions. What's different at the end of it? Is that like, can you actually measure that? You know, rather than just kind of get stuck in conversations about, where am I going to go? Let's try and figure that out. And it's a funnel approach. You get all the way down to the really specific thing and you learn how to measure that and you work with people in that.
Yeah. And you're studying, what did you say, PhD?
Yeah, so I'm doing my doctorate at the moment, and it's anxiety disorders and obsessive compulsive disorder in what's called the perinatal period.
Oh, so going deeper kind of into it.
Yeah, so I'm kind of studying why people... So the perinatal period is the period of pregnancy and 1 year postnatal. So I'm looking at anxiety disorders and obsessive compulsive disorder in that time period related to pregnant women, because I work in the maternity services.
Why does that, will that get worse while they're pregnant?
Substantially.
When they're pregnant?
Yeah, so you're most vulnerable for domestic violence and a mental health problem when you're pregnant and in the 1 year postnatal. The most common cause of death for new mothers in the 1 year postnatal is suicide. Not a medical problem, suicide. And I suppose that the rates of obsessive compulsive disorder in the perinatal or the postnatal, I suppose, more population increases by up to 500%. So it's much higher, and the reason being is that 30% of new mothers experience what's called adjustment disorder, where they really struggle to fit the routine, the baby, different things like that. Sleep gets impacted, appetite gets impacted, sex drive gets impacted, concentration gets impacted, and they really feel like they're losing that sense of self. And part of the reason for that is that, like, you've got this triangle between person, partner, and parent, and for most of your life you're kind of selfishly, I suppose, up here in person, right? So a bit of self-interest theory, it's all about you. And then you kind of tune into your teens, you start meeting kind of boys or girls and start learning to share that line between like, what do I need to do for them? How do they reciprocate that for me? And then after that, you kind of go into parent, and then you're all in on parent. Like, there's no partner, there's no person. You're kind of not doing your girls' nights out. You're not doing your date nights with your partner. You're kind of all
focused. It's probably 10 times worse as well if the fella leaves.
It can be. Sometimes it's a blessing. It depends on how helpful he is. But yeah, oftentimes it can be very unhelpful, especially if he's promised to stay and then just kind of bails. But that's the kind of study of my doctorate, is why at that stage of life is OCD and anxiety so much more prevalent, and what can we do to treat it more accurately. So I'm looking at different treatment approaches and trying to blend them all together. Yeah,
that's mad, isn't it? Thanks for coming on. If anyone is looking out to reach out or maybe do some CBT with you, where can they find you? What's your social media handles?
So the social media handle is actually only Instagram, so it's at cognitive_Conal. And then the website is cbtsolutions.ie, and we offer online and face-to-face. And at the moment, there's probably a little bit more availability in the online, purely because we are way more flexible with kind of availability. And for people that are kind of considering whether they come to us or they go to somebody else, there is no difference in outcome between online and face-to-face therapy. The only reason I would maybe encourage people to go face-to-face is if you're involved in domestic violence and you can't speak safely in your house, or you've experienced extreme trauma and you need maybe a safe place to contain that. But otherwise, online will be just as effective.
Yeah. Thanks so much for coming on, Conal.
Thanks a million for having me.
Thanks for listening. I hope you've enjoyed. If you're looking to reach out, you can find us at Unlock Potential Podcast on Instagram or at Demi's Nails and Beauty.ie. See you next time.